Good morning, can you hear me? Good morning, are you able to hear me?
Good morning, Professor Jonathan. So we are ready here. So are you ready, sir?
I'm ready to go. Can you see my slides on the screen?
Yeah, we can see you also.
Great, terrific. It's very difficult to hear you. So I'm just going to continue. Thank you very much for inviting me to talk. I've just heard of the challenges of bringing our patients' pressures down to the low teen levels. And so I'm going to talk about neuroprotection and really move to look to the future. This is all about developing drugs that are adjuncts to intraocular pressure lowering and in some ways take off the pressure of needing to get everyone's intraocular pressure down to 10. Now, the problem that we all face is that glaucoma being an optic neuropathy, we currently have no treatments that actually directly target retinal ganglion cells. And so new approaches are needed to bring this class of medication to the clinic. The only really substantial study that has looked at a neuroprotectant in glaucoma is the memantine study that many of you will be familiar with. This was a very well-funded study with over 2,000 patients who were treated with memantine for 2 years. But unfortunately, both of these phase 3 studies did not reach their primary endpoint. And this really put neuroprotection research back a very long way. But if you read the summary paper that came out very recently, Bob Weinreb is one of the lead authors, they came up with some interesting proposals in this discussion as to how this study could have been better designed. They also came up with 2 recommendations, and that is that we really consider alternative clinical endpoints that show change over shorter periods of time, as this would allow us to do much more cost-effective neuroprotection research. And secondly, that these short-term changes would need to obviously predict longer-term progression rates in glaucoma. So this is something that we've been addressing. Now, you're all very familiar of the relentless progression that some of our patients sadly face in glaucoma. But if you look at the panel on the right-hand side, the visual field progression, although in this case there is clear progression between 1991 and 2001, if you look at the 2-year intervals for each segment, it is sometimes quite difficult to determine whether or not that patient has in fact progressed. And this is the challenge we face in clinic, where with current endpoints, we really struggle to see progression in many patients unless it's over a very long period of time. Now, part of the problem is that most patients actually progress fairly slowly. This is data from Europe, from Anders Heil's EMGT study. And what we see is the majority of glaucoma patients are progressing at slow rates between 0 to 1 decibel per year MD. And this really creates a challenge with respect to doing any form of neuroprotection research. So the question that we posed a number of years ago is it possible to further cut the time taken down to determine if someone with glaucoma is responding to treatment or not? The paradigm that we all read in our textbooks is that in glaucoma, ganglion cells go from being healthy cells to dying. But in fact, what was probably really happening is that there's this injury state that a ganglion cell will enter into and really has the potential to recover from. And I'm going to show you some very quick data in a second to talk a little bit about visual recovery. And what we posit is whether visual recovery in response to intraocular pressure lowering or in response to a potential neuroprotectant could act as a surrogate marker that will predict a change in longer-term glaucoma outcome. And it's this neurorecovery, as we call it, that we believe holds potential in really driving forward neuroprotection research. And we call these injured, non-functioning ganglion cells comatose ganglion cells, and this may be what the coma in glaucoma is all about. Is there evidence for visual recovery in the clinic? This is a very busy slide intentionally because it shows a number of studies that have all looked at different forms of visual recovery in glaucoma patients over time. The one standout here in the bottom left-hand side refers to a paper from Bob Casson in ophthalmology, where they showed an improvement in contrast sensitivity in open-angle glaucoma patients in response to increasing vitreous glucose levels using intensive drop regime for glucose. And this was particularly interesting as it may suggest that ganglion cells are bioenergetically compromised, and that if you increase energy substrates, you may improve the function of retinal ganglion cells. What about individuals, and I'm sure we've all seen in our clinics, individuals whose visual fields seem to have improved, and there's not necessarily a learning effect. Here is a set of fields from a patient that I operated on in 2008, a young tennis coach who came in with high pressures, was sporadic about taking his topical medication. I performed a trabeculectomy, and what you can see is pretty early on his visual field started to improve, and even 8 years after surgery, a substantial improvement in his visual field over time. So certainly some of our patients maintain the capacity to improve function. We've taken this into the laboratory to really study the process of neurorecovery in retinal ganglion cells, and we do this in mice by insulting their ganglion cells by raising intraocular pressure to quite high levels for a very short period of time, usually 50 millimeters of mercury for 30 minutes. And using the Espion color dome from diagnosis, we measure inner retinal function in mice. And this is the sort of readout that we see, is that mice, after a very short pressure challenge, lose ganglion cell function. This scale on the x-axis is in days, but in a young animal, by 7 days, we almost see complete recovery. But this shows us that we can measure loss of function and then recovery function in a mouse eye that's been subject to intraocular pressure elevation. Now, older animals, interestingly here in red, also show the capacity for recovery, but the recovery process is incomplete and it takes much longer. And so we're now in our laboratory studies looking at ways in which we can make older animals recover better and behave more like younger animals. And we published some papers on this, which I don't have time to cover here. This is data from Bang Bui's lab, from another lab, which uses exactly the same model. And they've charted here very nicely how you get this improvement in inner retinal function, in ganglion cell function over time after a single intraocular pressure challenge of 30 minutes. We measure a scotopic threshold response, which is largely derived from retinal ganglion cells, using standard ERG protocols. Now, we very much like the ERG because it allows a functional dissection of the retina. In mice, we use a scotopic response called the STR, and in humans, we find the photopic response, the photopic negative response, which is also derived from the inner retina, largely from retinal ganglion cells, is a robust response that we can get in most of our glaucoma patients. And I'm going to show you the data from a recent study that we've completed, which suggests that we can measure an improvement in visual function in response to a potential neuroprotective agent. We use the Espion, which is the gold standard Electroretinogram, but also have more recently moved to some portable devices, which we've modified extensively to really measure the photopic negative response, the ganglion cell response in response to a flash of light. And here you see Xavier, who's a mathematician who works for me, really demonstrating the electrode and the setup that we use. It takes about 20 minutes to measure an ERG. These are light adapted patients. They don't require dark adaptation. But these studies still have to be done in a very careful manner in order to get robust data from them. One of the first studies that we did was to look at the effect of intraocular pressure lowering on the photopic negative response. I'm just going to show you this very briefly, but what we see here on the left-hand panel in the black dots is the response of a patient group who had a 30% lowering in intraocular pressure. And you see this improvement, significant improvement in intraocular pressure in a proportion of patients, not in all patients, but in a proportion of patients. And this then led us to start saying, well, could we get a similar improvement in ganglion cell function in response to a potential neuroprotective? The neuroprotective that we tried was vitamin B3, and we really chose this for two reasons. One is there was some very strong evidence from rodent studies. This was published in Science in 2017 by Pete Williams and Simon John, where they looked at an inherited mouse model of glaucoma and found that one of the earliest changes was signs of mitochondrial damage and a reduction in nicotinamide, which is the substrate for complex 1 in oxidative phosphorylation. So mitochondrial damage and evidence of bioenergetic compromise. And they proposed that if you supplemented these mice with vitamin B3, which replenished NAD levels, that you would reverse glaucoma. And this is in fact what they showed. We were interested in this study because we had previously shown that complex 1, where NAD feeds into the electron transport chain, is compromised in a significant proportion
Professor
of glaucoma patients.
Jonathan, may I interrupt you? Sir, could
Yes.
you please summarize in 5 minutes? Because we have a next session coming up.
Okay, so I'll skip forward to the end of the study. This was a crossover design looking at nicotinamide versus placebo. And we looked at the ERG every 6 weeks, as well as OCT and visual fields. And what we found, I'll skip to the data slide, and this is the key slide here, was that nicotinamide led to a significant improvement in inner retinal function that was measured in a number of different ways, both in respect to change from baseline, but also change to placebo. So what this data shows us, and I'm going to skip right to the very end, I won't show you all the data. This is now online in Medical Archive. But what we found was a significant improvement in inner retinal function in response to nicotinamide. And this is the first time that we've seen that we have, we believe, robust evidence of visual improvement in glaucoma. We now need to go on to see whether this translates into a longer-term visual improvement. And this whole concept about driving neuroprotection to work together with intraocular pressure lowering, I think is a key priority to really face the upcoming burden of glaucoma in all healthcare sectors. So thank you very much for your attention.
Thank